Welcome to Med Scrolls, Manchester's underground med school. This is the one-stop shop for high-yield clinical content relevant to your undergrad exams. Join me as we unravel the scrolls, one disease at a time. Welcome everyone to the very first episode of this brand new podcast. I'm Hamza, the host and a third-year medical student at Manchester University. I'm pleased to welcome Dr Pippa Watson, a consultant rheumatologist. Welcome.
Thanks for having me.
And Dr Pippa, what are we here to talk about today?
So we're here to talk about giant cell arteritis, otherwise known as temporal arteritis or GCA.
And tell us more, what is GCA?
So it's a type of vasculitis, so inflammation in blood vessels, and this particular one tends to affect the medium and large sized blood vessels in the body.
And tell us a bit more about the pathophysiology of how this comes about.
So as with all of our conditions in rheumatology, this is an autoimmune disease where we get inflammation where we don't want it, in this case in the different parts of the blood vessel wall. So we get lots of inflammatory cells coming in, lots of release of cytokines such as IL-6, which you'll see more about when we come to the treatment, and that causes thickening particularly of the intima of the blood vessel wall, and that can cause problems with blood flow, which leads to some of the symptoms and problems.
And GCA, what kind of patient typically would you expect to get this?
So this is a condition that affects older people, so the peak onset is between 70 and 79 years, doesn't really happen in people under 50. It's most common in people of Northern European descent, more common in females than males, but still quite a rare cause of headache. So not everyone that comes into a GP surgery with headache is going to have this. In fact, it's going to be the minority of patients, but it's a really important one to think about. Typical presentation is an elderly patient with a persistent temporal headache, perhaps with some flu-like symptoms. They may or may not have scalp pain, jaw claudication. Visual symptoms are really, really important to check in on. And as I said, they're usually systemically unwell, perhaps with a flu-like illness, and they may or may not have some limb claudication. Just a quick word on the claudication, so particularly the jaw claudication, people sometimes get that confused with TMJ pain, but jaw claudication is pain that comes on after prolonged chewing, so it's not a discomfort when you open your mouth or when you start chewing. It's a really important point.
Great. And you mentioned quite a lot of symptoms there, and one would assume that those are quite broad and vague symptoms. So what are the other differentials you want to be thinking about?
I think a really important question to ask is whether the patient's had a headache before. A lot of headaches that we typically see, like migraine, tension, cluster headaches, will be recurrent. So that would always make me sit up if they hadn't had this type of pain before, if they have presented with headache. Other important differentials and questions to ask about are any ENT problems, any sinus infections, TMJ dysfunction, ear problems, any neck pain, so referred pain from the neck can cause this type of headache as well.
I see. And a patient walks in, you're worried about GCA, how are you going to examine them?
So I think the main thing is to focus on the blood vessels for the GCA part of it, and that would be palpating the temporal arteries, looking to see if they're tender at all, if they're thickened, and if there's any reduced pulsation, if the blood flow has been affected. You also need to think quite broadly, are there any carotid bruits? Are there any differences in the peripheral pulses? Are there asymmetrical blood pressures? And then also just more generally, for example, is there lymphadenopathy or organomegaly if you've got a constitutionally unwell patient? Because we often pick up other things like infection or malignancy. So you just have to be really thorough when you examine these patients.
I see. And you've examined this patient, you're really suspecting GCA. What are the next line investigations?
So we usually do a full set of the sort of usual blood tests, but the inflammatory markers are really helpful, and very often they will be significantly elevated, for example, greater than 100. We used to do quite a lot of biopsies, but now we only hold that back for cases where we're struggling a bit. But our first diagnostic investigation now is ultrasound. Really important to get that done quickly, ideally within 24 hours.
And you've made this diagnosis now. How would you treat them?
So steroids, and I would just urge caution in terms of starting steroids. If you're worried about this, you need to get specialist advice. You need to get the patient on steroids as soon as you can. So it's 40 milligrams of prednisolone or 60 milligrams of oral prednisolone if they have any claudication symptoms. If they have any visual symptoms, they need to go same day to the eye hospital for assessment and possible IV methylprednisolone. It can unfortunately cause visual loss, which can be irreversible and can affect both eyes. So it really is an emergency, this condition, particularly if there are any signs of eye involvement.
And would you recommend starting steroids before you've made an official diagnosis?
So we would usually start steroids on the basis of a history and examination, and if available, blood tests. And the key to doing that really is to take early specialist advice. So if you're not a rheumatologist or someone who's familiar with this condition, you probably need to pick up the phone and speak to someone who is, and they can provide advice by phone and see the patient in a timely manner.
Great. And you've mentioned the visual loss that can be irreversible. Are there any other complications that you'd be worried about?
So the visual loss is probably the one that we worry about most. There are lots of complications that can happen. Unfortunately, people can have cerebrovascular events. I've seen areas of scalp or tongue necrosis. It can also just make people feel very unwell. We haven't mentioned polymyalgia rheumatica, which can be associated in up to 25% of conditions. So yeah, I think those would be the main things to watch out for.
And finally, you've given a really good perspective about GCA. What are things that undergraduates should be thinking about when they're on their rheumatology placement?
So I think my take-home messages would be always to think about this, and particularly in older patients presenting with a headache, to be really thorough and make sure that you're not missing something else like a malignancy, and to start steroids, and encourage anyone you're working with to start steroids and speak to a specialist if you're concerned about the condition. It's not very common, but you will all see it in your careers and you don't want to miss it.
Great. Thank you very much, Dr. Pippa. Thank you for listening. That's all for today's scripture. If you enjoyed this episode, follow the MedScrolls channel. Until next time, stay bodacious.